Greetings, everyone. We're so excited to be here today. I'm Dr. Joshua Chodosh, and I'm here um, with my terrific colleague and friend Sue Borson. And we're very excited to bring you our second in a series of webinars on health systems approaches to early detection of dementia. This is from our CDC-funded BOLD Health Center of Excellence on early detection of dementia. And I want you to know that both Dr. Borson and I have now a long and pretty extensive experience as dementia detectors. Sort of feel like I'm a detective now, and importantly as clinicians. And we've had the privilege of building some really important and deep partnerships with others across the country who have implemented detection and diagnosis programs, and these have really been nationwide. We're really excited to have you join us today, but I wanted to share with you some quick reminders. First of all, this webinar is recorded, and we will share this with all of you via email, and it'll be posted on our website, which I really encourage you to visit. If you have any questions during the webinar, please use the Q&A box that's located at the bottom, should be located at the bottom of your Zoom window. It's also really important to us to know how we're doing with these webinars. So at the end of this webinar, we're going to invite you to complete a short survey. So we kindly ask that you just take a couple of minutes to complete this survey so that we can continue to tailor our webinars for our audience. We are very serious about this process and making sure that we do the very best that we can. We'll share the survey link in the chat, and the QR code will also be on the screen. Finally, I wanted to just let all of you know that we're going to be holding another webinar titled Implementing Dementia Services System-Wide, Becoming a Prepared Leader. Like this webinar, we're really excited about this upcoming webinar where we will discuss dementia leadership preparation, and we hope to see all of you on February 12th, which you should be able to see on the screen here. So we're really excited that you're all here with us today, and particularly excited to hear from our colleagues from Wisconsin. And now I want to hand this over to Dr. Borson. Sue?
Good morning, good afternoon, everybody. Thank you, Josh. Welcome. We're so pleased to present our guest today, Dr. Nathaniel Chin and Ms. Krista Pfister, for our webinar, Statewide Dementia Screening, Linked to Diagnostic and Social Services, Implementation Strategies and Lessons Learned. So Wisconsin has been a longtime leader in this effort, and this webinar today is kind of a beautiful cap for us on understanding how their program has evolved and works now. Dr. Nathaniel Chin is Associate Professor in the Department of Medicine and Division of Geriatrics and Gerontology at University of Wisconsin. Dr. Chin sees patients at the Health Memory Clinic, where he also serves as Associate Program Director. He's Medical Director of the Wisconsin Alzheimer's Disease Research Study, the Wisconsin Registry for Alzheimer's Prevention Study, and the ADRC Consortium for Clarity in ADRD Research Through Imaging, known as Clarity. He has created over 170 podcasts on AD research and caregiving topics under his podcast called Dementia Matters. Ms. Krista Pfister obtained her Bachelor of Science in Community Health from the University of Illinois, Urbana-Champaign, and Master of Social Work from the Jane Addams College of Social Work from the University of Illinois in Chicago. After training, she dedicated the next 13 years to community case management for a long-term care funding program for clients 65 and older. She then made a transition to become a clinical social worker at University of Wisconsin Health Geriatrics, serving primary and specialty care clinics, including Memory Assessment Clinic and Memory Triage Clinic. Okay, so to get us started, please tell us what motivated you to start your dementia detection work. What impact did you hope to have, and how did you measure it?
Chris, I'll go first if that's okay. And I do like the phrase dementia detection and dementia detector. So I think I will use that going forward. And for me, that was really, I think like many people who are probably watching this, it was a personal experience. My father was diagnosed with mild stage dementia in his early 60s. And that really changed my career from what I thought would be infectious disease on the West Coast to coming back to Wisconsin to do geriatric fellowship and then specialize in memory care. And that family experience was really impactful for me in that I saw firsthand the barriers that exist in getting an evaluation, in being told that you have dementia, and being told what the plan could be or would be depending on your own goals of care. And it wasn't because people had malicious intent. It was because the system wasn't set up in a way where patients and their families can talk to primary care for a long period of time, where you can get a quick referral and then access to a memory specialist. And so I saw that as the biggest barrier. And then going into the field, I recognized how much more there is that we can do for people, but it all starts with the diagnosis. It all starts with that detection. And so because of that, I've spent a lot of time focusing on detection, on the earliest symptoms, and working with social workers and neuropsychologists to figure out the ways to do that. When you ask the question about the impact, is really to get at the earliest symptoms, to have families and people living with change know that there are things that we can do. And how we measure it, we'll talk about in a few minutes, but I'll turn it over to Krista.
Thanks, Nate. So for me, I actually realized throughout my graduate school field placements, my love of working with older adults. My second placement, I was at a Chicago area VA hospital where I had the opportunity to facilitate a support group with World War II veterans. And that led me to kind of my first job in Madison out of grad school, working at a community case management organization for individuals 65 and older who were on a long-term care funding program. And part of my time there, I was able to co-case manage with a nurse for our more medically complicated clients. And so really learned the value of an interdisciplinary team, and kind of drove me to apply for the job at the geriatric clinic, where I've been a number of years working with interdisciplinary teams every day, whether it's in our primary care clinics or specialty care, which includes memory assessment clinic and the memory triage clinic.
So in your program in Wisconsin, there's a job description or called dementia specialist or dementia care specialist. This was a pioneering effort that launched, I think, around 2015 by Kristen Felton in public health to craft a role for people who are non-professionals in non-medical professionals, not nurses, not social workers, but workers who were trained specifically to teach about dementia, to identify dementia. And how is there any confusion about what that term means in your experience? Or is it clear in Wisconsin that a dementia specialist is this non-professional linker person with kind of a foot in both clinical and community and public health activity?
Nate, do you want me to take this one?
Sure.
Sure. Okay. So the dementia care specialist, the state of Wisconsin has a dementia care specialist in every county and tribal region. It is a free service offered through the county with the goal to provide ongoing education and support to patients or care partners, families, friends. So as a clinical social worker in the memory clinic, our role, there are 10 of us, and our roles are actually to be interviewing the collateral contact to get this picture from another person's perspective about how a person's doing functionally or with mood, behavior, memory issues while the patient is having the testing or meeting with the provider separately. And so we don't get to meet with the patient. We're gathering this collateral picture that then we review in the interdisciplinary staffing before the dementia specialist or memory specialist, like Dr. Chin, goes in and meets with the patient, care partner or collateral to review test results and discuss any potential diagnoses. And so We may pepper in resource information throughout our interview with the care partner or collateral if things come up that are concerning. We will likely give the dementia care specialist contact information as a resource that we think they should pursue, but we're having our whole conversation without knowing the test results or knowing if a patient is going to be diagnosed. So proactively, we give them that contact information, but our role is very much gathering this important information. So we distinguish our role as absolutely we get pulled in when they come back to memory clinic. If they're seeing a provider for a follow-up, we might have a provider say, gosh, they're really struggling with this diagnosis, or gosh, that care partner or the spouse seems really burnt out. Can you just go talk with them? Then we're revisiting the role of doing some intervention in clinic, some support and discussion about what's occurring, but then again, offering that dementia care specialist resource as an option, a free option in the community.
So
And I would add,
go
sorry,
ahead.
Boo,
Go ahead, Nate.
I would just add that, we don't hear in the clinic that people are confused about the dementia care specialists in the community versus what we are doing in the clinic. And I think a lot of that is, even though I might identify as a memory care physician or a memory specialist, I'm a geriatrician. I'm a proud geriatrician, like I know you both are. And so I think they see our team as a memory team, and that hopefully they will see that we reach out to the community, to the dementia care specialists. I'm not sure how much people know the degree and training of the dementia care specialists, but they certainly know they are trained, and that we as the memory clinic program trust in their abilities and that we work with them. And so I think maybe the names could be confusing to people, but certainly not the roles, because we do clearly identify during our visits what people are doing and how we work together. But we do make that intentional effort of explaining, this is what we're doing today in clinic, this is who this person is, and this is how we're reaching out to the community.
One of the things that's really unique about the state of Wisconsin is that you have a very large number of memory clinics sprinkled around the state. At last count, I think it was 40. And my understanding, and correct me if this is wrong, each of these clinics belongs to its own special institution, a hospital system or other kind of clinical entity. The idea, I think, that we want to understand more is about how the public health dementia care specialist interacts with these 40 memory clinics, and what are the pathways and workflows do you have in place to facilitate this interaction?
Yeah, I'll start with that one. And so it is really quite fortunate. We have what's called the Wisconsin Alzheimer's Institute. And in that institute, one of our missions is to have memory clinic education and actually help programs create memory clinics, regardless of their institution. There is no preference for academic versus community, UW versus anyone else. And so it works really well in that there's ongoing educational sessions, there's webinars, we meet together and we talk about difficult cases. So we try to create these collaborations and relationships. And through that education, we do then invite and bring in our dementia care specialists, or in each county, the aging and disability resource centers, so that those relationships can be strengthened as well. One of the things that we do, and again, this is through trial and error, but also just case examples, is that we make sure that we are explaining what the dementia care specialist is, or at least the Aging and Disability Resource Center, in the memory clinic visit. And so the providers and the social workers, so multiple times in a single visit, will bring up, after this clinic, you can reach out to these individuals, or we will help you reach out to these individuals. And then we actually provide some of the resources that are created by the dementia care specialists in those counties. So we're not only using our own institution. And so that makes it very portable, that each of these clinics can not only meet with the dementia care specialist, they can use some of their educational materials and then talk about it in a very personalized way, because they are different in each of our counties.
Yeah, that sounds quite well integrated, actually. What organizations or funding or programs or partnerships have allowed you to develop this really incredible network of service delivery?
Well, I guess I would start with, in the model, the Wisconsin Alzheimer's Institute model has been very helpful in establishing a collaboration. So it's run by geriatricians. So inherently, we believe in the team. And so
Yeah.
Krista has already mentioned, in just our own clinic, we have 10 social workers and we're hiring 2 more. And that's quite an investment. But that is something that we talk about routinely with the other memory clinics, that if we wish to be successful and actually provide resources and services, it isn't going to be done by the physician or the advanced practice practitioner. It is going to be an expert in social work or someone with similar training or experience. And so I think we start with that person, that role is really the connection to the community, to the dementia care specialist. And I'll Krista speak to that. But then I would also say we are fortunate in that RUW, the University of Wisconsin, is also spread throughout our states. There's different universities. And so there is a true investment into the state. We call it the Wisconsin idea, community-based research in the community, education to the community. That means faculty members are frequently going to dementia specialists or going to the Aging and Disability Resource Centers to provide education. And then we conduct research with these organizations. And so we have multiple ties to them, which allow for those relationships to really foster. But it all starts with the team. And so I don't know, Chris, if you want to add to that, but I certainly think that we've invested in that team.
Krista, maybe you can include this in your comments though, but I think our listeners are probably asking, what does it take? From your vantage point, what does it take to be this dementia specialist? Is there specific training? Is there, accreditation process? Maybe you could speak about that a little bit.
That's a great question. And so, I'm not considered a dementia care specialist as they are through the Aging Disability Resource Center. So I'm a clinical social worker. I have a master's in social work, as all our clinical social workers have, at the Geriatric Clinic. Throughout the state of Wisconsin, the various dementia care specialists at the ADRCs, my understanding is they have a varied background. They all do a consistent training to become the dementia care specialist. But like, for example, we have a full-time and part-time dementia care specialist in Dane County. And I think one is an occupational therapy assistant by training, has a number of years working in that role, where our full-time dementia care specialist has a background in psychology and more mental health. And so, we hand off many times. Our role as the clinical social worker is to connect people to community resources. So that's kind of the role in terms of providing education support in clinic, but then ultimately for this good ongoing continuity of care, maybe you have a new diagnosis, maybe you're a caregiver that really needs some education, or maybe I just interviewed 4 family members who live across the country and they all have varying levels of understanding of where their loved ones at, and even education levels of their understanding of what dementia is, where that dementia care specialist is this neutral party who can have these lengthy conversations with patients, way more than the bandwidth we're able to provide in clinic. We absolutely do care partner support and can set up separate appointments, individually meeting with care partners for patients, but we absolutely bridge the gap with the referral. And the dementia care specialist similarly says they partner with us. They want a release so we can work together.
Mm-hmm. So, but is there a train? So if somebody else was trying to do this somewhere else, is there a training program? Is there something that is kind of off the shelf, if you will, that people can use to get started? Certainly your skill set speaks a lot to, even without this training, speaks a lot to many of the issues that are transferable across different populations. But then there are those unique aspects and sensitivities that are needed when we're talking about this condition, dementia specifically.
And I would say, without being involved in the process directly, that yes, there is a training. And fortunately, at your next webinar, you're going to have the person who's going to have that specific answer for you, as Kristen Felton is really the leader in.
Good way to tee it up, I guess, right?
Yeah.
Yeah, you did. You really set it up nicely, because we can't speak to it specifically. Although I will say, in speaking about relationships, the memory clinics as well as the UW institution, we have many educational events, webinars, seminars where we then have a room full of dementia care specialists, and we are talking about Alzheimer's disease, Lewy body disease, dementia, mild cognitive impairment. It depends on the topic of interest from the group itself. They will request certain things, and then we will meet with them, sometimes virtually, but more recently, we just had an in-person event at the university talking about the newest therapies and what does this mean for evaluation and screening. And it's an opportunity not only for a presentation, a didactic, but then Q&A so that people can ask, well, we're seeing this in the community. What is it that you want us to be saying that's appropriate? What are you doing in clinic so that they can actually prepare people in the community for what these things look like? And this happens fairly regularly. And so I think that relationship building, but that the ability to do these things ongoing has allowed for people in the community to go to a dementia care specialist, then go to the memory clinic, and then come back to a dementia care specialist for good continuity.
That's great.
You know, there are many directions that are kind of being opened up in the Q&A, and a lot of the questions are having to do with funding and who pays for what, how the dementia care specialists are supported. And by the way, I'll point out, thanks to one of the people who commented in the Q&A, that all dementia care specialists have at least a bachelor's degree, many have master's degrees, and a number have additional professional degrees and certification in health-related activities. So I think the role has really developed over the last decade or so to become a much more kind of to attract, on the one hand, to attract people from multiple disciplines concerned with aging problems to actually fill this role around dementia, which is I think quite an interesting evolution. But back to the question, there are so many questions people want answers to, but a lot of them, as I say in the Q&A, are about funding. Who's paying for these programs, at what level, and how is the funding sustained? That's a kind of a big question, so I'll toss it to both of you guys.
And it's an important one because ultimately you have to pay for the great work that's being done at these aging disability resource centers. The first thing I'd like to say is how nice it is to have such broad training and backgrounds. And that really does enhance the network because we're learning from each other. And so having people not just in one field, but multiple fields does make for the cross collaboration to be more successful. But ultimately, the payer sources for us in Wisconsin is the state, because what they have done, and it didn't start with every single county has a dementia care specialist. It was a few counties, and one person was having to cover many different counties. And so in the beginning, as Kristen will talk about at the next webinar, I mean, I imagine it was not an easy process, and there was a lot going on, but they showed the effectiveness and they showed the benefit to the community, because this is ultimately about our state community, that then more and more legislature, and I would imagine more and more lobbying for it, and it went through and it was passed so that we would actually pay for the state, Wisconsinites pay for that service in these counties, so that we can have these experts. And so, there are other programs like the memory clinic doesn't pay for dementia care specialists, but we certainly invest in our team who then works with their team. And the more we can work well together, the less redundancy. And so therefore, we hopefully won't have to be paying for the same resources or the same time. But it is covered by our state.
That's great. Sue, I think one of the things, and it really came from one of the questions in the chat, obviously you're interacting with primary care providers. And so you probably see the range of both knowledge, experience, and inexperience across the board. And so how would you describe your influence or impact on primary care providers, and how well they manage this, how well they even manage the initial discussions? Because I'm sure you've seen the whole range as people come to you, both everything from relieved to terribly upset. So can you say more about that?
I would say it starts with case by case, in that every provider is going to be different, right? So every primary care provider is going to have a different level of comfort. But then through our Wisconsin Alzheimer's Institute network, we submit anonymized data to the central hub, and that's run by Dr. Cindy Carlson, so another geriatrician. And so that's one of the roles that Krista has. So talking about investment, our social workers collect this data and submit it, and we can see trends in how many people are coming to the memory clinic with already having had a cognitive screen or coming with a collateral historian, or what their diagnosis is when they come for these initial visits. And I can speak to our clinic at UW in particular. We see more and more people coming in earlier and earlier. And so meaning 10 years ago, before I was at UW, my colleagues would talk about people coming in and being diagnosed with moderate or severe stage dementia, and the conversations being more palliative care, hospice oriented. And that is not what we're seeing now. We're seeing more people coming in with mild cognitive impairment and mild stage dementia. And I think that speaks to, the community efforts in raising awareness and education. But I think that speaks to primary care being able to hear a complaint, and then it varies whether or not they get a cognitive screen or not, but then saying, we know we have this network, we know we have the dementia care specialist, we're going to send you to both, have this worked out, and then come back to us so that we can continue to take care of you. So we do see that cultural shift. And we do have metrics through the WAI. And I think that's really the result of the work that's being done.
Sure, and that certainly we see this nationally as well, and in our own individual experiences, probably across the country. But I think there's another aspect of this which I'd love to hear you talk about, which is, to what degree do you help our primary care providers talk about this problem and give this news well, as opposed to sometimes what we do often hear?
It's a really good question. And I guess I would say through the WAI network, we host events where many of the providers can be primary care providers. And so through those educational workshops, through CME webinar presentations, we can do this. And honestly, I guess for me personally, through my podcast, trying to raise that type of awareness and education, but it's not an easy thing. And primary care is incredibly busy. As a person who's not a primary care provider, I recognize that they have less time than I do with my patients and more patients per day. And so, I'm not giving you a straight answer, because I don't think there's not a direct pipeline from what we're doing to educating primary care providers, other than through our continuous interactions with them through patient care. We are helping in that regard.
Sure.
So could I put that? Oh,
no, I was just going to really quick follow up, Nate, because I know I've got you on the hook here a little bit, and I don't mean to put you on the spot, but with all of these educational venues, we often experience, we put on these, what I think are terrific programs, but the smallest representation are physicians. Yes. Every other discipline is represented. And so in your programmatic initiatives, what kind of participation are you seeing? And if, to the degree that you can know, whether it be through your podcast or through these other educational events, are you getting penetration into the primary care community? Are they showing up? Are they participating? And if so, why? What's the secret sauce?
Yeah, well, I think the secret sauce is having great presentations come in. So you came to our WAI event, and there were many primary care providers at that event. And so I think we have those metrics as far as in-person and virtual attendance, because we will ask people what their backgrounds are. But those are organized events. And so, there are less organized ways. And so I don't have the breakdown as to how many physicians listen to the podcast or attend a presentation. But many of our faculty will create CME presentations, and those are available for people. But we don't have the exact numbers or a clear understanding of the penetration into the physician world. And I certainly think, I would imagine Kristen's going to talk about that at the next meeting. How do we do that? Okay. And I don't have a great answer.
Great, thank you.
So, Krista, go ahead.
The dementia care specialist, I know last time I talked with her, she said that she has run so many cognitive screening clinics with the intent to get those baseline cognitive screeners in the community with the idea that she could forward those to the primary care physicians, but she said most cases, probably 90% of the cases, patients decline that. And so she gives them the written test that they've completed and said, you should bring this to your next primary care physician's office as a talking point. It's really important. And then it's really in the patient's hands, or the person who had the screening done by the dementia care specialist at one of her kind of clinics where it's all screeners. And then I know in geriatrics, for every new patient establishing care, just primary care, they're 65 and older and want a geriatrician, we do a cognitive screener as part of our patient appointment for social work. Just screening, it's the intent. It's as important as physical health, mental health, cognitive health. It's important to just do that. And so just making it more of a normalized conversation, and the importance of getting that baseline.
Right. I think you said something really interesting, and something I've heard from Kristen too, about people who are being screened in the community, not necessarily wanting the information to go directly to their clinician. They want control over that. That I think is a really interesting avenue to pursue in our future thinking. I want to bring this back a bit to something we're learning from recent interviews with primary care docs, mostly family medicine, primary care, internal medicine, which is that is the relationship between the primary care clinician and the specialist clinician. That there's a very mixed reviews that we're getting from primary care docs about how they relate to specialists and how helpful those specialists are in providing primary care with information they can use. And I think without calling out any particular type of specialist, we know there are among medical providers, there are specialists in neurology, cognitive neurology, behavioral neurology, geriatrics. And so there's a range of people who would be called specialists, including geriatric psychiatrists. But the helpfulness of those specialists to primary care seems to me to be something that's kind of on the table now for conversation. How do we best use, if our contacts are principally through clinical channels, your patient comes to me as a specialist, I see the patient, we see the patient as a team, we create a care plan for the patient, we send that care plan back to the primary care doc. How useful is that as a means of educating primary care clinicians? And is there a way to broaden out the use of that kind of training to a wider audience nationally? I think that's a vague question, but it's more about exemplars of care plans and how they can be used by a primary care doctor rather than through the echo mechanism or through a clinical exchange, a personal clinical exchange, to take these as exemplars of a process of specialty primary care interaction and teach about that. Is there a role for that? Would that be helpful in as part of training for primary care clinicians and specialists in how to manage that primary specialty relationship more effectively for the patient and family?
Well, I think, Sue, yes, and I think that's relevant for all the disciplines beyond dementia too. I think we have to leverage the technology that we have and the realities of patient care. And so there isn't time on the primary care or the specialty side like there used to be, where you could actually have phone conversations for 20 minutes and talk about a single patient. However, we do have more technology than we've ever had, and the ability to share information, I think, is really important. The ability to collaborate still, I think, is fundamental to this, because we need to know, well, what information is it that you really need? How do you want that presented? How should that be laid out? I'm still a big believer, as I know most in my profession hate the electronic medical record and notes. I still believe it's fundamental to be able to share in a very thoughtful yet concise way what you think and what the plan would be. But you want to know from the receiving end, what is it that you actually want from me? and how it should be shared. And so I think there's lots of room for improvement. I certainly think with AI technology, we would be able to create these templates and have this shared more quickly than what we're doing. But I also think what's really nice about the way our system has been is because we have a team, it's unlikely that it does happen where I will talk with primary care providers on the phone. That does happen. But more often than not, a primary care provider will have a nurse or a medical assistant reach out to our team for clarification, or we really need this. And Krista is one of 10, hopefully 12 social workers with advanced knowledge of not only the visit, but our field, who will then be able to communicate that over the phone. So it is a warm handoff in that regard. And so the more you build a team, the more you can actually have live exchanges of information with the referring providers.
Yeah.
And so I would say on the specialty end, the bigger the team we can have and the more we invest in the importance of communication, the more likely you're going to have these opportunities. And it's beyond just one patient, because those interactions are teaching people, what it is we do in the clinic and what we're able to offer.
Stu, there's lots of questions in the chat, and I wonder, one of the things we've been focused on our ambulatory population. And so one of the questions really relates to what degree you've had influence or interactions, if you will, with nursing facilities and other levels of care where people may not have the same access to ambulatory care.
Mm-hmm.
And Krista, do you want to talk about your experience with our patients from nursing homes?
Sure. I mean, certainly we follow, and we have nurse practitioners who follow patients in nursing home settings. We very much as a social work team defer to the nursing home social worker if that's where the person's residing, but are able to collaborate. So similarly to what Nate was saying with collaborating with other primary care providers or through the electronic medical record, we're able to confer with the social worker at the facility. That's really our first, contact to collaborate care if there are issues. Talking about what might occur during a clinic appointment, or talking about different, strategies or supports. The dementia care specialist is limited where they cannot get involved with a patient who resides in a nursing home or assisted living, but they can still support the care partners of somebody who lives in those settings. And so I guess we're lucky in Dane County, we have a dementia crisis specialist. I don't know if we're going to talk about that person later, but it's through our adult protective services department, where if somebody is having housing, concerns or maybe real behavioral issues that are jeopardizing a placement, that nursing home social worker might benefit from knowing they should call the dementia crisis specialist to get them involved, because she can absolutely get involved when somebody's in that nursing home setting or assisted living and, help kind of stabilize the situation. So I'm all about collaboration. I mean, it's one thing I love about being a social worker. I love the electronic medical record. And if I'm talking with a patient or collateral and there is an issue occurring and I see they have a PCP appointment next week, and it's within our system, so the information can be routed. I'm absolutely routing my note to loop in the primary care provider, like, hey, heads up, just had this conversation today. I'd really want you to touch on this next week at the appointment. And it is showing kind of what our role is, because it is unique having 10 social workers present at a clinic, and our role is very different from what like a social worker at a nursing home would be. And so that's, really our I guess our role collaborating with a nursing home is we would see the patient, but social work would be deferred to that person. We do a handoff to that person. Social worker.
That's great.
Yeah.
So we're seeing a lot of comments in the Q&A, questions and comments about undersupply of specialists and the really terrible wait times that exist in many, if not most, locales. I would say most. I think that one of the reasons that we invited the two of you to present this webinar with us is because you're so far ahead of many different states and communities in the way you think about population health for dementia. And I'm sure that there are frustrations within your own environment too, But I think the level of frustration is orders of magnitude greater for many of the people who put questions in the Q&A, that 6 months, not unusual to get to a specialist. The specialist is oftentimes not even a comprehensive carist, if you will, the way a geriatrician does think comprehensively, multimodally, multi-domain thinking is part of geriatrics, whereas most specialists identified as dementia specialists would be thought of as neurologists and other people who work on the brain. We focus on the brain, and it's those specialists who are, and geriatricians too, who are very hard to get to in many locations. I don't know how to really get us into any kind of meaningful dialogue on this issue in this webinar. I mean, a lot of the answer has to do with what states have been willing to do in funding dementia programs as a state initiative, recognizing that there's population burden here, that there is a social responsibility that a state may have to address this issue that's
Right.
so prevalent in an aging population. But do you have other comments that you might, okay, Josh, you would like to
No, I
answer?
think I don't want to add to this commentary. I really want to hear from both from Nate and Krista, but I think, Sue, there's a question in the chat that is that's for me is very relevant to this issue of workforce. And that is really around your sense from the viewpoint of primary care practices, how this is working for them. And some of that is very granular in the sense of what follow-up do you get after you've done something that goes out to the primary care, and also from both a satisfaction standpoint as well as that's great, but we still need this. Are you getting into that kind of more back and forth relationship with your medical community, with your primary care community across the state or locally for you to continue to find new ways of raising the field broadly?
Well, yes, and I would say these conversations are ongoing, as I'm sure they are for everyone who's writing the questions. We still struggle with wait times. It's not nearly as bad as I think other parts of the country. And I think one of the things that maybe as a memory group that we have really emphasized to our colleagues across the state, and we have a very rural state as well, is that first thing is to really diagnose a syndrome and to really get at, is a person having mild cognitive impairment? Is this dementia? Because you don't need a specialist to be able to get to that. You certainly want comfort in training and being able to, and we work with providers on language to use, and that's through our WAI network. But
Right.
so we have made an extra point to say, and this is what the dementia care specialist, screening can happen outside of a clinic, the program that Krista had mentioned. And so if we can get more and more into the space of being able to talk about thinking ability, whether that's through the annual wellness visit or not, but being able to talk about cognitive complaints and feel more comfortable in getting to a diagnosis of MCR dementia, then you make a referral to a specialist to get at a cause of that. Because if we're thinking Alzheimer's specifically with all the new things that are happening in the field, then having a specialist talk to that. And so ultimately, you're still seeing the same number of patients because people are making their way, but it's a different staggering of timing. And in our program, we've actually created, as Krista mentioned in her intro, what's called the triage clinic. And the reason we call it a triage clinic is we have really put together the ingredients of what do we think is really critical. Gather information from a patient, their family member, look for reversible causes like depression, sleep apnea, medications, do a quick cognitive screen. Do not expect to provide a diagnosis, but talk about areas where we can potentially address brain health or express our concern for something, and then have them come back for a second or third visit. And so recognizing time is a limiting factor. We break one visit into 2 or 3 visits. And so that gets people in sooner. And that means maybe we don't provide the diagnosis, but we're certainly providing intervention ideas, modifiable risk factors, and then eventually we get to this diagnosis and a more advanced treatment plan. And that has really reduced our wait times. And our
Wow.
our patients are feeling like they're being heard, a plan is in place. Maybe there's some frustration. I need that diagnosis and that treatment, but more often than not, we have an idea of what's going on. Here's a plan. We will continue to modify it as we learn more, and people are feeling satisfied with that.
And maybe, Nate, just to call out really quickly, what I heard you say is you're also giving yourselves and your patients and families opportunities to build a level of trust with you so that when you do get to that diagnosis, it's a better conversation because there's already a relationship that supports that information and your interactions with these individuals around what can, for some people, be tough news.
Absolutely. Absolutely. We're not rushing things, and not everyone wants a 45 or 60-minute thinking test. And so we're building an understanding, and we're educating the public about what is normal aging, what is not, what are potential causes. And so it feels more fluid than this abrupt visit that's really long and a diagnosis.
And I think a lot of with the social work part, interviewing the collateral contact, whether that's, a spouse, family member, care partner, it's almost like a therapy session, unintentionally for that person where they're just unloading on all the things that, they're struggling with, where even though they might not be coming back to the full memory assessment clinic for that neuropsych testing piece until, 3 months later or whatnot, they can still have that resource information. They've still kind of touched base with social work on what are the key issues occurring, no matter what the cause, and they can start getting connected with those resources right away.
Yeah. Sue, I know we're running short on time and we want to get to takeaways, but I wondered whether or not we shouldn't ask both Krista and Nate what, for others who are listening, how to get, if they haven't done this, how to get started, and what you wish you had known or done when you were getting started in this work.
Chris, I'll start with, why don't you go first?
Gosh. Well,
You saved the best for last.
I think that especially coming from the case management world in the community where you're like doing it all and you're the go-to person and you're really just very in a good way, overly involved and able to support your clients coming to a clinic setting, you've got some restrictions in terms of, the bandwidth that your role can provide. You can't be a case manager and still get all your other functions done in that role. And then there's also healthcare privacy and HIPAA, where you might identify, man, that person could really utilize getting connected, yet they need to give permission. And so I think the trickiest thing is that scenario of the patient that lacks the insight to their deficits and the care partner who is, drowning and not knowing what to do, yet I can't without the patient's permission because they're their own person. It's different if they lacked medical decision-making capacity. I could get permission from an activated healthcare agent, but the patient who might have a diagnosis or not, but lacks insight, I can only offer suggestions and then have to wait to where the patient and care partner are at, even if it's, care partner could reach out to a dementia care specialist to start those conversations, but it's really better if everybody's on the same page. So I think that's the hardest thing for me, is just that restriction and just not knowing they need the help. There are barriers to them being able to get connected for whatever factor.
I guess I would say standardizing the process and doing it in a similar way for people. I don't think physicians in particular, and then advanced practice providers, like algorithms. They want to have the leeway to do things their way. But I think when something is as overwhelming as dementia, it is easier to have buckets and to have processes in place. And I have found, if you standardize that, when someone comes in with a complaint, these are the things we need to know about the complaint. These are the labs we need to have. This is the screening, and this is the different options based on the score. This is when we make a referral. Obviously people are all unique, and we want to respect that and be as personalized as possible. But from a system perspective, starting out, having those things drawn out in a process map is really helpful. And then knowing what team members are going to do what, because frankly, collecting a history on cognition could take hours. But if
Yes.
you use a certain standardized form as a semi-structured interview, you can still get the personal information, but still get really the key points that you need to make the next step. And I think that's taken multiple iterations in our own program, but we're at a point now where it does feel like the system is there, and that has allowed for us to be more efficient so that we are able to cover more ground with less people. Though we do have a lot of people, we're able to account for all that time.
So a couple of points here emerging from your comments. One is to ask whether on your website or elsewhere you provide that the kind of a roadmap for people who want to start to think this way about the essentials. So maybe answer that one first. Is there an available roadmap for starting up a process of developing a service?
And so
what is it that you need to get to? Yeah.
Yeah, so I would say our Wisconsin Alzheimer's Institute, the clinic network, is the point of contact for that, because what they have done is help create clinics, and so they have this sort of process of what it looks like. And on the website there is a resource and a contact for someone to reach out to. And so yes, I mean, we do have these materials. I don't think it's available right on our UW clinic website. But it does exist, and people can be contacted with that. So I would say the Wisconsin Alzheimer's Institute.
Great.
Great.
So another perspective on this is that, just reading quickly through the Q&A, there are so many different perspectives on dementia and cognitive impairment that people bring to this, from the highly personal to the highly abstract and brain-based. And I think that one of the things that we need to focus on a little bit more as we go forward, we as a collective group of people concerned about wellness for patients and families, if you will, is what is it that the goals of care actually are? Because they are not the same for different people. They are not the same. What is even the spectrum of goals that one might have? Someone who focuses exclusively on the brain wants to see, we want to stop progression of Alzheimer's disease. We want to diagnose AD and stop progression. Someone else is saying, I don't know how I'm going to live with this, given that my marriage wasn't very good to start with, and now I'm saddled with this responsibility of caregiving for somebody I've been mad at for a long time. I mean, they're polar opposites in what people think about and care about. I'm wondering if there's a way for us to come together in future efforts around the very different kinds of goals, the domains of goals, if you will, that we all are trying to address. It's just as dementia is not just one thing. Goals and circumstances fall into so many different categories. And I think that's being reflected in our Q&A. Josh, I'm feeling frustrated, maybe you are too, about how short our time is and how deep questions are that have come in and how few of them we can really address.
Yeah, we haven't done a full service to all of our listeners, and we want to partially apologize for that, but I have a suggestion. And I think we could do this on our website, that we would love to have both you, Krista, and me send these questions. We can send these questions to you. We can then post your answers to these questions without, very brief answers, of course, and we know there's quite a few questions. And we can post that on our website for our listeners to check in. I think that would be a really nice way to follow up with this. We do only have, I think, right now, a matter of 5 minutes left, and maybe I know we had talked about having some takeaways, and before we get to just that for just a minute, I want to make sure that our listeners will be remembered to complete a quick evaluation by scanning the QR code that's on the screen here. But I wondered if you could, I'm going to really put you on the spot here, because I know we could have 2 more hours of this discussion, but if you could distill a key takeaway into no more than 2 sentences for each of you, what would those key takeaways be?
I'll let you go first.
Yeah, that is, geez, you should have prepared me for this, Josh.
I'm sorry. I'm
yeah.
sorry.
Okay, so as far as the key takeaway from what we've talked about today, it requires a team to not only identify but care for people living with change, and that team consists of those in the community and those in clinics. And there has to be a relationship, a bi-directional relationship in between those 2 communities.
Pretty darn good, I'd say. Krista?
I second that. I think the importance of social work in the clinic to be able in the moment to get pulled in, like when the patient comes in or collateral, and they're really needing to have that in the moment conversation is, important and imperative, but then also our ability to collaborate with our great resources and dementia care specialists. I really do think it's helpful to the social worker in addition to the patient or care partner. 2 heads are better than 1. And it's actually very good bi-directional relationship, like Nate said.
And so this whole dialogue began with the idea that public health has a role in dementia detection and care, and that role began to be realized through the creation of the dementia care specialist within a Department of Public Health, which then expanded and expanded and expanded with state support, and help to bring the community and the clinic together in ways that are the envy of many people
Yes.
on this webinar today.
Yeah.
And people are very eager to learn where they can fit in this process of developing services in their own communities. There's a lot in the chat about that.
Right.
Go
And
ahead,
I think, just maybe a really nice way to close this session would be to hear from either of you where, what's your next move? Where do you hope to take this work from here?
I'll go first, Krista, because I do want to, I'm looking at the Q&A, and thank you for everyone who's writing questions. The memory screening in the community, I think, is a really important direction that we're moving. And the program is actually partially funded by BOLD. So that's a plug for the great work that BOLD's doing. And so Dr. Lindsay Clark, who is one of our professors, a neuropsychologist, a part of our WAI network, it's called Memory Screening in the Community Program. And this is, so someone asked, is this evidence-based? Well, we're trying to build that evidence. And so there's training, there's education, there's collaboration with faculty, with memory clinics, and dementia care specialists, because that environment is different than a memory clinic environment or a primary care environment. And there might be better access, or we need to improve the opportunities for people in the community. And so I see a direction of how can we start the conversation sooner? How can we identify a thinking complaint sooner? And then how do we plug people into a healthcare system when needed? And everyone needs to be plugged in, even if it's just for brain health, for a normal aging brain. And so I do think this direction of going in the opposite direction, going from a memory clinic back to the community with the help of dementia care specialists is very exciting. And I anticipate more and more work going in that direction. And that's really partly because of the BOLD group.
Fantastic. So we are at the top of the hour, or at the bottom of the hour, depending on your perspective. I want to thank everybody for attending what was, I think, for us, just a terrific webinar, and want to thank both you, Krista and Nate, for all of your amazing work, but also particularly for being with us today and giving us such useful and compelling information. So thank you very much.
And thanks to everyone who was with us today. We'll do our very best to answer those questions we weren't able to get to in real time.
Take care. Have a great rest of the week, everyone. Yes. See you on the 12th.
Thank you so much.
Bye.
Bye-bye.